Hello, good afternoon to my dear students. Today we will discuss about the important chapter of endometrial carcinoma. What is endometrium? Where it is situated? Uterus is having three layers. One is endometrium, the innermost layer, and the myometrium, which is the middle layer and thick layer contain muscle fiber, and the outer is the serosa, outer layer of the uterus. That is the serosa layer. After the three layers, endometrium is very active and it is participating in every month in a menstrual function. Now we'll know about what is endometrial carcinoma. Endometrial carcinoma develops when the cells make up the inner lining of the uterus become an abnormal and grow uncontrollably. That means normally they will follow one pattern of the in the body. Every cell will have its own methodological and systemic replacement, but sometimes there may be abnormal proliferation of the tissues that may lead to malignancy. It constitutes about 20 to 25% of all genital cancer in developed countries. 5 to 7% of all genital cancer in developing countries. So, what are the risk factors for endometrial carcinoma? The age is very important. Unlike the cervical cancer, which is very common in the postmenopausal woman, but the endometrial carcinoma will come in a little later age group, like 55 to 75 years of the woman. It is common in a nulliparous woman. Usually we can find this nulliparous woman. And low parity. Unlike the cervical malignancy, where it is common in a multiparity, here a low parity woman are the high risk factors for carcinoma. And the woman who had an early menarche and who had a late menopause, these are the women who are prone for endometrial carcinoma. Etiology. So unopposed estrogens and high estrogens. So what are the factors that are responsible for high estrogens is HRT after menopause. Those women who are having an hormonal therapy, chronic non-ovulatory cycles, and it has a familial predisposition, and Lynch 2 syndrome with breast carcinoma, anorectal endometrial carcinoma. See, malignancy has a multifocal origin. And the woman had a breast carcinoma, it doesn't mean that the other organs are free from malignancy. And it will be multifocal, means different organs will be involved in the body. When tamoxifen, a selective estrogen receptor modulator used in the treatment of breast cancer, carcinoma breast, they can give tamoxifen. Increased risk of endometrial carcinoma because it has estrogen agonist action on endometrium. And obesity is one of the factors that are responsible, and diabetes also, and hypertension. So this is called, when a woman is obesity, having hypertension and diabetes, they are more prone for endometrial carcinoma. That is called corpus cancer syndrome. So in the obesity causes insulin and IGF is more and increased ovarian androgens that may lead to even here aromatization of the androgens. There's a decreased SHBG that may bioavailability of estrogen is increased, the amount of the estrogen that is increased. All this obesity may lead to endometrial increased levels of estrogen. That is because of that may lead to increased hyperplasia. And the PCOD, polycystic ovarian disease, these people are high risk group for endometrial carcinoma. And infertility also. The infertility women are prone for endometrial carcinoma. Associated with fibroids, 90%. Carcinoma with fibroid both can be coexisting because both are hyperestrogenic conditions. Feminizing ovarian tumors also. Feminizing ovarian tumors, they may produce high levels of estrogen, and oral combined pills have a protective effect on the, because of oral combined pills have a protective effect. Adding progesterone to HRT therapy decreases the risk for the endometrial carcinoma. Endometrial hyperplasia. The conditions of excessive proliferation of cells of endometrium. It occurs as a result of high estrogens. Atypical endometrial hyperplasia are the risk factors for developing endometrium. The endometrium start proliferating. Starting it is endometrial hyperplasia. Next come to cystoglandular hyperplasia, and coming to next atypical hyperplasia, and then go for abnormal cells. The pathology, the endometrium curatings are plenty. If you do the patient with the suspected endometrial carcinoma, if you do the DNC, the curatings are plentiful and pale and friable also. Histology, the types of endometrial carcinoma is adenocarcinoma constitute about 75%. Clear cell, next coming to clear cell carcinoma. Next is squamous carcinoma. Next coming to serous carcinoma. Next coming to mucinous carcinoma. These are the incidence of endometrial carcinoma. See the picture, polypoid fundal growth. Typically early polypoidal fundal growth, we can see the ultrasonography. Majority of the 60% are adenocarcinoma. They can be divided into 3 groups according to the degree of glandular differentiation: mild, moderate, and severe variety. Grading, grade 1. On histopathology, we can see the grade 1, grade 2, and grade 3. This is not a clinical classification. This is only histopathological. That means it is the grading of the malignancy can be done during intraoperative period depending on the extension of the malignancy into the tissues, and also by histopathological examination. In grade 1, well differentiated gland forms are conspicuous, mitotic figures are moderately numerous. And grade 2, patchy differentiation, gland forms are much less prominent and many deposits consist of infiltrating single cell columns and are solid masses. Grade 2. Grade 3 is this type consists of solid masses of malignant cells of varying sizes and shapes with a little or no stroma. The mitotes are numerous. Next, adenoacanthoma, also we can see in some cases adenosquamous carcinoma. Both can be squamous cells and glandular cells. Both can be combined and they may represent as a adenosquamous carcinoma. Other histological path is recognized that is apparently of all prognostic significant. Clear cell carcinoma. See, this tumor has a poor prognosis and is included with a grade 3 adenocarcinoma, clear cell carcinoma. It occurs mainly in the elderly people. Slow to spread because of lack of lymphatics in the endometrium. See, usually the malignancies will spread by the lymphatic spread here because of no lack of lymphatic cell. This is a very slow progress of the disease. We can see the metastasis can occur in the tubes and also in the parotic glands and in internal iliac glands, or it can occur in the ovarian tissues. Locally, it can occur in the vaginal spread, vaginal metastasis. Laterally, it will go into the pelvic lymph nodes. This is the different types of spread of the endometrial carcinoma. Local spread is myometrium, endocervix, and vaginal wall. And tubal malignant cells can pass along the tube into the same way that peritoneal spill may occur during the menstruation. This accounts for isolated ovarian metastasis. So sometimes the malignant cell pass through the tube and implanted into the ovarian tissue and causing ovarian metastasis. And lymphatic spread, the incidence of this, it is much debated. It seems to be somewhere between the 10 to 13%. All pelvic lymph nodes, including the internal iliac and the parametrium and the ovaries and the vagina, may be involved, probably with equal frequency. Lymphatic spread is more likely to occur when the tumor is anaplastic and the uterine wall is deeply invaded. This is the lymphatic spread of the carcinoma. And distant metastasis can occur like any other malignancy in the lungs or liver or brain or a tumor or bone. Clinical features, the menorrhagia or irregular bleeding in perimenopausal women. So whenever you clinically how to suspect obesity women having hypertension and diabetes, having menorrhagia, postmenopausal bleeding at later age, with irregular bleeding in the perimenopausal woman, we have to rule out the endometrial carcinoma. Postmenopausal bleeding in a postmenopausal woman, the woman may be obese, diabetic or hypertensive. Pain and lump in advanced cases we can see. Lump due to the tumor itself or a fibroids associated with a malignancy. And metastatic vaginal growth also sometimes we can see. Because most of the endometrial carcinomas will be presented asymptomatic, 7 to 10%, because of very slow progress in the disease. Other causes of postmenopausal bleeding, one is senile endometritis. Because of the lack of estrogens, the endometrium is prone for infections in the postmenopausal woman. That is called senile endometritis. And tubercular endometritis. Sometimes there is a genital tract is involved by the tuberculosis, and that may cause tuberculous endometritis. Atypical hyperplasia, it is one of the hyperplasia of the endometrial tissue may lead to atypical hyperplasia and polyp sometimes. The endometrium will, malignant cell will sometimes endometrial polyp can also present like in the postmenopausal period, like a bleeding per vaginum and lesions of the lower genital tract. Sometimes any ulcers or any trauma to the tissues may lead to bleeding in the postmenopausal bleeding. What investigations you want to do? Pap smear only 30 to 50% is sensitive and it is not reliable. A normal pap smear at the screening power, we can see the benign squamous cells, you can see here in the figure. Here it also a benign endocervical cells also we can see clearly. Abnormal pap smear, a mild dysplasia, irregular perinuclear cytoplasmic clearing, which is the key characteristic feature of identifying SPP visually and a pap smear. We can see here an abnormal pap smear showing severe dysplasia. A pap smear showing squamous cell carcinoma, the cancer that is arising from the squamous cells, and abnormal pap smear showing adenocarcinoma, the endometrium. Endometrial glands will become malignant and they will manifest like a adenocarcinoma. And investigations, aspiration cytology from the uterine cavity every 6 months is an effective in screening, especially in the case of high-risk cases and those on tamoxifen and HRT therapy. Aspiration is done by PPL curate and other aspirator and Vibra aspirator and Novak curate as an OPD procedure. But sometimes it is very difficult because of postmenopausal, the internal os is tightly closed. If there is a difficulty, we can do on that in the body and the short under any analgesic, under the cover of analgesics, and the patient should be more comfortable. And fractional curatives is the important investigation that can be done to diagnose endometrial carcinoma. Histological study of the endocervical scrapings before the dilatation, followed by cervical dilatation and curatives from the isthmic body of the uterus and as fundus separately. What is the difference between the DNC and fractional curative? DNC under anesthesia in a extended lithotomy position. We can do that, and after cervical dilate, first pass the sound and dilate the cervix and then do the curative. That is a DNC. But in case of fractional curative, first under anesthesia in extended lithotomy position, before passing the sound, we can take the endocervical curative and keep it separately and label as endocervical curative, and then pass the sound and then curate the uterine cavity and keep the endometrial curating separately and sent for histopathological examination. This is to diagnose whether the malignancy is arising from the which part of the tissue. And the hysteroscopic and biopsy. And the hysteroscopic directed biopsy also we can take from the with a carefulness. And the complications of spilling the cancer cells into the peritoneal cavity is a possibility because we will distend the whole of the uterine cavity with the fluid. These fluids will enter into the malignant cells enter into the fluid and can pass through the tube into the peritoneal cavity. Ultrasound will give you the endometrial thickness, how much it is involved, and we can diagnose a polyp and associated any ovarian pathology or ovarian metastasis also we can see through the ultrasonography. And other investigations are Doppler ultrasound. We can do the Doppler, show irregular vessels within the area of the endometrial thickness. We can see here very clearly. Low resistance can be seen here in the endometrial malignant lesions. Sonosalpingography. It is to detect the endometrial polyp. Any polyp is there. And the sagittal transvaginal ultrasounds can show the endometrium with a thickness of 44 millimeters. And also a large area of mixed echogeneity is suggestive of a mass. We can see clearly in the picture. Sonosalpingography. And the tumor marker that is CA125 is not specific for endometrial cancer. It is usually raised above 35 internationally per ml. And the CT scan is one of the investigation superior to MRI in detecting ascites, bowel, and omental metastasis. These are all can be, metastasis can be better visualized through the CT scan. The radiation exposure is only the disadvantages. MRI is superior to CT in detecting myometrial involvement and nodal enlargement. So we can do the CT, we can know the involvement of the myometrium and also the nodal enlargement, and more expensive and time consuming. But it will because of the soft tissue extension can be better visualized with this MRI than the CT. This will help to know the extension of the malignancy into the uterine wall. The other investigation, X-ray of the lungs and bones to rule out the metastasis, and PET scan to reveal the metabolic activity. And the staging of the endometrial carcinoma can be done only after surgery. Stage 1 is tumor confined to the uterine body. Stage 1A is tumor limited to endometrium, and 1B is tumor invade less than half of the myometrium. Stage 1C is tumor invade more than half of the myometrium. This can be done by cut section of the specimen staging. And stage 2 is tumor extending into the cervix. 2A is cervical extension limited to endocervical glands. 2B is the tumor invades the cervical stroma. We can clearly see the stage. Here the endometrium, stage B, stage 1 also, stage 1C, it is invading into the myometrial tissues. Here in the stage 1A is the glandular involvement. Stage 2A is see the cervical, it is endocervical glandular and involvement only, and the cervical stroma also involved in the case of stage 2B. And the stage 3 is regional tumor spread, that is, the tumor invade the serosa, adnexia, peritoneum, and ascites will be formed. It is stage 3A. And 3B is vaginal involvement, metastasis is present. And 3C is tumor spread into the pelvic lymph nodes. The pelvic lymph nodes are there, it is stage 3C. Coming to the stage 4, it is bulk pelvic disease or distant spread. The tumor has spread to the bladder and rectum anteriorly, posteriorly, and that is stage 4A. And B is distant metastasis is present. Inguinal lymph nodes also will be involved. See the stage 1A spreading into the vagina, and B also, and here stage 3C also we can see stage 4A metastasis and inguinal lymph node stage 4B. And the spread is direct spread. A tumor can spread into the endometrial cavity to the cervix from through fallopian tube to the ovary and peritoneum. It can invade the myometrium, reaching the serosa, and very rarely invasion into the pubic bone also. This is a direct spread from the malignancy to the surrounding area. And lymphatic spread is from the pelvic and parietic lymph nodes, and inguinal lymph nodes also is involved. And hematogenous spread it is very rare, but may spread to the lungs also. See the involvement. Most metastases occur in adjacent structures and peritoneum. The advanced case of distant metastasis can occur most commonly into the lung, but occasionally the liver and vertebrae, other bones, and supraclavicular lymph nodes also will be involved. Preoperative workup. First is endometrial biopsy. We have to take ultrasonography. For suspected advanced stage may need a cystoscopy and sigmoidoscopy. CT of abdominal or pelvic, possibly chest, and labs we have to do like a routine investigation, liver function test, ECG, RFT, LFT, and X-ray chest also. The treatment is total abdominal hysterectomy in stage 1, bilateral salpingo-oophorectomy without partial removal of the vagina. Peritoneal saline washings are taken for cytology and opening the abdomen, and the abdomen content are fully examined. Vaginal hysterectomy with the removal of the ovaries sometimes can be done, sometimes with the laparoscopic assisted, has equally 5 years survival and a lower operative mortality in appropriate hands. See, treatment hysterectomy removes the uterus and may also remove the cervix totally and also in the vagina radical, and different depending on the extension of the disease. Stage 2 is carries similar prognosis to stage 1 and it may be treated as a stage 1 only. 2A. 2B is with the clinical invasion of the cervix has a poor prognosis than the stage 1 and radical hysterectomy can be done. And pelvic lymphadenectomy and para-aortic lymph nodal sampling are also indicated. With a combined of local and external radiotherapy is also alternative treatment in stage 2. Coming to stage 3, following the staging laparotomy, radical hysterectomy, lymphadenectomy, para-aortic sampling, and removal as much as malignant tissue is possible. We can do omentectomy is also carried out. Stage 3 disease limited to the pelvis may be treated by radiotherapy. And stage 4 is treatment of this stage is designed to control tumor growth and other symptoms. Surgery, radiotherapy, and cytotoxic therapy and adjuvant progesterone therapy have a place in that. And treatment radiotherapy, see external radiotherapy, internal radiotherapy. Also, they have given brachytherapy, and external radiotherapy is teletherapy. So, the treatment is radiotherapy plus chemotherapy. Chemoradiation is advisable. Before radiotherapy, check for the hemoglobin, rule out the infections, and remote control after loading technique. These are all can be watched for complications of radiotherapy. The overall results are better than the carcinoma of the cervix, not because it is less malignant tumor, because the treatment usually given earlier. Post-menopausal bleeding is much more difficult to ignore than the irregular bleeding of a younger woman. So if they come early, then the treatment will be very good. And also because of the slow prognosis, the woman can be diagnosed by only DNC and then she can be treated early when compared to cervical cancer. Recurrence of endometrial cancer. The incidence of the recurrence within 5 years is in the region of 30% and is accepted along with the 5-year survival rate as a measure of effectiveness of the various systems of treatment. The majority recurrences appear within 3 years of treatment. Early recurrence has a very poor prognosis. Progesterone has a role in the treatment. Many endometrial carcinoma are hormonal dependent and the progesterone have been used as a part of combined primary treatment as well as for the recurrent or metastasis growths. The 15 to 50% of the recurrences will respond mostly. Medroxyprogesterone acetate 400 milligrams to 600 milligrams daily is the most commonly employed, and in addition of that, tamoxifen may improve the response. Chemotherapy, the cytotoxic chemotherapy has a limited place in the advanced recurrence. Single agent therapy with adriamycin, cisplatinum, and cytoplasmide and other drugs will give response rate between 20 to 40%. The staging, diagnosis, and what is the prognosis of the carcinoma? Staging, diagnosis, and the extent of myometrial invasion and histopathological grading are the most important prognostic factors. And in stage 1, 5-year survival rate is 85%, stage 2, 68%, stage 3, 42%, and stage 4 is 22%. And follow-up is the best done by history and examination. Every monthly we have to ask the patient to come for 2 years and 6 monthly thereafter. And X-ray chest for every 6 to 12 months to know to know any extension of disease like metastasis. CA125 also we can do. And intravenous pyelography and CT scan are not indicated as a routine follow-up the patient. Thank you.